interest of time, we'll start. My understanding this is a webinar, a men's health webinar across the 5 businesses. So for those who don't know me, my name is Andy Heath. I'm the HR director of the consulting business, been with Deloitte for just over 4 years. And it's my absolute pleasure to be a facilitator as much as I can on this webinar today. Lamise and her team kindly asked me if I'd like to be the facilitator, and by that really is it's means of introducing our guest speaker today and facilitating any questions after. But Lamise reached out to me in particular because this is something that I have been talking to her about in terms of the last few years. I'm 47. I am, in terms of what I suppose the second half of my career, as people would say, or even the second third of it. I have known a lot in my role. I get to speak to a lot of employees, as is natural for someone in HR, but also I get to speak to a lot of men whom have concerns in terms of workplace, personal health, mental health concerns, and also I think it's important to share that in the last 4 or 5 years, I've actually lost probably 4 or 5 friends or friends of friends from mental illness as well. This isn't just about mental illness, but it is a big factor of it, and that is something why Lamise asked me to if I would be the facilitator, because it's something which I've been saying. We see a lot of, and as rightly we should, female wellness programs, but I was also concerned that we provide some focus on men. If anyone, I suppose I'd just like to say, if anyone wants to reach out at any point, any stage, have discussed with me anything, that I'm always all ears. I'm probably also extremely busy like everyone, but I will always make time to listen, support where able, but just to hear people. So my door and desk is always open. So on that basis, I will hand across to the professional in this, which is Dr. Juan. So Dr. Juan, would you like to perhaps introduce yourself and give an overview of your session, please?
Hello, everybody. Thank you for this nice invitation. My name is Juan. I am consultant urologist, now more than 20 years experience. I'm coming from Spain, in Barcelona, and now I'm working since 5 years here in Emirates. I'm based in Abu Dhabi, and now I have started also in Dubai in this American Spine Center. And then I have this opportunity to share with you my thoughts about one of the main topics in men's health care, that is the prostate cancer, and especially with conservative options we have, how we can try to preserve quality of life in case we are affected by that disease, by that problem. I will start the presentation. Let me check. Okay. In general, the prostate cancer has an annual incidence of 40.5 per 100,000 male population here in Emirates. This is lower than in Western countries. Okay, historically, this incidence has stayed lower, but this has increased in the last years, as we will see. This is the only available study that is almost 20 years now, talking specifically about the epidemiology of this cancer in United Arab Emirates. And it stated this number of incidents, and the conclusion was that the prevalence of this carcinoma in Emirates, like in other Middle East countries, was really very low compared to Western countries, despite the diet, because the diet was not really different. Despite the high intake of calories and consumption of animal fat, this incidence stay much lower than in general. It was thought that maybe some genetic or environmental factors were involved, but was not clear the reason. What we have seen is in the last years, and according to the last cancer registry from the Ministry of Health, that is from 2019, these numbers have changed. And then the prostate cancer has increased the incidence. In general, all around the world, this is the annual incidence, 1.4 million people diagnosed around the world in 2020. And here in Emirates, the total number of cases was 172. It means 3.9% of general population, but this population includes female and male. Then, if we have a close look at the numbers, we will see that the real incidence in men was double than 20 years ago. Now, the real incidence is around 8.8%. And we know from the registry that the numbers of cases of colorectal, skin, prostate, and leukemia cancer has been really increased in the last years in the Emirates. So we had an incidence of 4% 20 years ago. Now this incidence is almost double. It's variable, it depends in different countries on the population, geography, ethnicity. And about the mortality, in general, is high in population of Africa. It's intermediate in USA, and it stay very low in Asia. In Asia and Middle East, the mortality rates are really low. What we can say about this prostate cancer? What are the reasons? What are the risk factors that we could treat or focus or analyze? I will review what is in the literature, in the guidelines, what we know about some cases of hereditary prostate cancer, some risk factors related to metabolic syndrome, diabetes, cholesterol, obesity, dietary factors, some medications that could play a role in the prevention of the prostate cancer, and other potential risk factors. About the family history, hereditary prostate cancer, we know that men of Africa ancestry in the Western world demonstrate more unfavorable outcomes due to a combination of biological, environmental, social, and healthcare factors. In general, they are more likely to be diagnosed with more advanced disease, and only a small subpopulation of these men have true hereditary disease. True hereditary disease means more than 3 cases in the same family, prostate cancer in 3 successive generations, or more than 2 men diagnosed with prostate cancer at age less than 55 years. We know that hereditary prostate cancer is associated with a 6 to 7 year early disease onset, but the disease aggressiveness and clinical course seems not different than other ways. Related to risk factors, we know that Asians who immigrate to the USA have approximately half the risk of prostate cancer when compared to the same US-born Asian descendant counterparts, implying a role of environmental or dietary factors. But actually, we don't know really what are these differences. We have a table of different genes that are involved in this prostate cancer, like family cases that increase risk. There are some studies that identify some mutations, but we have still a lot to investigate and to study to be able to offer clear counseling and clear solutions in that way. You can see here all that table. This is available online, but in the practical way, it's offering no specific treatments or no specific solutions. In the risk factors, is also different studies in one and another sense. For the metabolic syndrome, we have seen studies that say that having a single component of metabolic syndromes, like hypertension, big waist circumference, is associated with a significantly greater risk. But in contrast, another studies shows that having more than 3 components of these metabolic syndromes was associated to a reduced risk. So it's like opposite results of both studies. It's not clear what's the role of the metabolic syndrome. Similar happens with diabetes. In diabetes, the use of metformin, very common drug used for the treatment of diabetes type 2, in some studies, it shows like could have a role to decrease the risk of prostate cancer, but in others, it shows no benefit, and there are no indications to use as preventive measure. Regarding cholesterol, statins, similar. Some studies shows that maybe statins could have a protective role in this disease, but at the end, they saw that there are no overall protection, so there are no indication to use the statins as preventive medication. In obesity, it seems that obesity could have an increased risk of prostate cancer, but it will be like low risk prostate cancer. It's not direct related to aggressive cases of prostate cancer. Dietary factors. Has been studied a lot of the dietary factors that could be joined related to the development of prostate cancer, but also the results are not very clear. Alcohol has been related in some studies, high intake of alcohol, but also total abstention from alcohol in another studies has been associated to higher risk of prostate cancer and mortality. Coffee consumption may be associated with reduced risk, could have a protective effect. Dairy products. There is a weak correlation between high intake of protein from dairy products and the risk of prostate cancer. Fat is not clear. There are studies that talk about the role of the fat, but not in a conclusive way. And also as protective factors, tomatoes for his ingredient lycopenes or carotenes could have a protective effect, but is not well demonstrated. Meat. Maybe there is a potential association between red meat, total meat, and processed meat consumption and prostate cancer. Soy, phytoestrogens. The phytoestrogens included in soy, the high intake was significantly associated with a reduced risk of prostate cancer. The total soy food intake has been associated with this reduced risk of prostate cancer, but in some studies there found also an increased risk of advanced disease. So there are studies in both ways. Some of the studies say that it decreased the risk. Some of the studies show that despite the diet, they develop an aggressive disease. Vitamin D, a use-safe association has been observed. With low or high concentrations, it seems that there are an increased risk of prostate cancer. Similar with vitamin E, there are an inverse association. The mainly nail cellulose levels reflecting long-term exposure has been found to be related to aggressive prostate cancer. Selenium and vitamin E supplementation were, however, found not to affect PCA incidence. So some studies say that vitamin E or selenium could be involved. Some other studies don't see a clear relation between. In general, we have all this table of different dietary and food studies, and there is no clear recommendation that we can give because the results, as you can see, are inconclusive. Also, with medications commonly used for the prostate treatment for hyperplasia and the symptoms, like finasteride or dutasteride. Finasteride has also been used to avoid or to treat balding. The use of these medications could have a preventive role or could delay the development of prostate cancer, decreasing the risk by more than 25%. These must be weighted against treatment-related side effects as well as the potential small increased risk of high-grade prostate cancer. Also the same, there are studies that favorite the use, than another study that says that in some cases increase the risk of more aggressive cancers. So based on these discrepancies of the studies, none of these treatments has been approved by the European Medicines Agency for chemoprevention. What is clear is that what was a myth during time is that the use of testosterone. What has been proved in different studies is that hypogonadal men, it means men that has low testosterone than normal range. If you use testosterone in that man, there are no increase on risk of prostate cancer. You can use testosterone safely and you don't have an increased risk of develop the prostate cancer. There are another disease that could be related. It seems that having inflammatory bowel disease could be also related to an increased risk on having prostate cancer. Balding was associated also with more risk. Gonorrhea increased the risk. And occupational exposure, especially in that study, in some of the studies related to the shifts, seems that night shift work could be increased with an increased risk of prostate cancer. Also, cigarette smoking was associated with an increased risk of prostate cancer death and with aggressive tumor features and worse prognosis even after quitting smoking. So there are a lot of studies, lot of research done, and the summary till now is that none of these factors has been clearly established, and there are no clear recommendations that we can give to avoid or to prevent the prostate cancer based in diet, habits, or style of life. Until this moment, there are still a big margin to study and to work on these fields because no conclusive results has been yet published. Exposure to cadmium, papillomavirus, estrogen insecticides, frequency of ejaculation, previous vasectomy, all these things are not clear really. Then we have a disease that is very prevalent, that has a high incidence, not so high mortality, and we don't know exactly how to prevent. There is a lot of discrepancies how to prevent. Then what has been the main rule till now is try to diagnose early and to treat the sick man. If you try to diagnose and prevent at early stages, you are supposed that you are going to save a lot of lives. And there were all the screening programs that were developed in the last 30 years. What was screening? The screening definition is population or mass screening is defined as the systematic examination of asymptomatic men to identify individuals at risk for a specific disease, and is usually initiated by health authorities. The co-primary objectives are to reduce the mortality due to prostate cancer and maintain quality of life expressed by quality of life adjusted gain in life years. This is a parameter that is called QALYs. This is what is the definition of screening and what has been done for a lot of years with prostate cancer. After all these studies, also the screening is one of the most controversial topics in urology and in men's health, because a Cochrane review of all randomized prostate cancer screening trials with prostate cancer mortality as endpoint was published 10 years ago and updated 5 years ago. The main findings of this review was that according to the main 5 randomized clinical trials that included more than 700,000 men, the global result is that the screening is associated with an increased diagnosis, but this increased diagnosis detect, sorry, just a moment. Here. Increased diagnosis, it drives to the detection of more localized disease and less advanced prostate cancer. But at the end, if we detect all prostate cancer and we treat all prostate cancer together, we find no specific survival benefit. There are no increased survival related to prostate cancer directly, and there are no overall survival. So if we want to do a screening to increase the survival and to heal the disease, we find that diagnosing all possible cases and treating all possible cases is not good. We are not solving the problem. We are not reducing the mortality because we are not changing it. Why? Mainly because...
Doctor, do you mind if I jump in with a question at this point?
Yes, please.
So I think I mentioned I'm in my late 40s, and I went for I think the screening part is important. A few people on this call may have questions. I remember doing my screening for prostate cancer. Actually, I did it on my turn 40, and it was perhaps what I might describe as quite an uncomfortable experience. But I understand that there are different ways nowadays of actual screening. Would you be able to give us an overview of what options people have to be screened for prostate cancer?
I will develop now. This is the main idea, to develop who should be screening and in which way you should be screening to really get a benefit in survival and benefit in your quality of life.
And how they would be screened, I presume, as well.
I will tell you, it needs some slides to be explained. Okay,
Perfect.
it's in the coming slides. It's
Thank
the
you.
focus of the speech. Yes, sure. So the main idea is that if we diagnose all the cases, we are not changing the overall mortality. Why? Because most of the prostate cancers are low grade or non-aggressive, and you could live a lot of years with that cancer and die for another reason, not dying from the prostate cancer. Then we must focus in diagnosing and treating the high-risk prostate cancer. If we diagnose the high-risk prostate cancer, we are saving years of life and we are improving your quality of life. And then all the screening must be focused on diagnose this high-risk prostate cancer. If we read here the slides, we see that we did a comparison of systematic and opportunistic screening. Systematic is do a screening for everybody. From the government, we say everybody from 40 years will be screening. And opportunistic is only when a patient comes to your clinic, you offer to do PSA or to do a screening about the prostate. But you are not looking for the patients, you are waiting that the patient comes to your clinic. This comparison suggested that overdiagnosis and mortality reduction in the systematic screening group compared to a higher overdiagnosis with only a marginal survival benefit in the opportunistic screening. The benefit of screening in reducing the mortality and the even more favorable impact on metastasis rate is counterbalanced by the side effect of screening such as increased diagnosis rates, which has led to overtreatment of mainly low-risk prostate cancer and subsequent treatment-related effects. Regarding quality of life, the beneficial effect of screening and the side effects seem to balance out, resulting in limited overall impact on the invited population. So, what it means? It means that currently, the national USA recommendation is against PSA-based screening. It was the main tool that we had till some years, and all the screening was made on PSA. And with this screening based on PSA, we were really not able to differentiate between low risk and high risk. Then the recommendation was against PSA base. Then it drives to a reduction in the use of PSA for early detection And then, after some years, we started again to detect higher rates of advanced disease because we stopped doing PSA. That was the only tool we had. Then we started to find higher rates of advanced disease that has been stopped years ago. Initial widespread aggressive screening in USA was associated with a decrease in PSA mortality, which has decreased for 2 decades since the introduction of PSA testing. Then they saw that we cannot ban the screening because really we were avoiding advanced cases, advanced diseases. We must focus again in diagnose and treat high-risk patients. The current USA national recommendation is for men less than 70 years of age is that the decision to be screened should be individual and should be consult and talk with the patient what are the benefits and what are the cons of being diagnosed with that disease. Finally, recognition of the harms of overdiagnosis and overtreatment had led to a redesign in the pathway for early detection. And then we must identify specific risk groups, not all cancers. We need to identify risk groups, individualize when we need to retest the patient, improve the indication for biopsy using different risk calculators, and mainly what is from now our main tool is the MRI. We will talk a little later, but the main tool nowadays is the MRI to decide when or when not to biopsy, to
Doctor,
target the biopsy. Yes, please, sorry.
just to jump in,
Yes.
we're at 12:28. I think what we want to do, I don't know how many slides you have left. We've got a good bunch of questions coming
Not so
through
much,
from our
really.
attendees. I just want to.
I will go quick now because we don't have a lot of slides.
Yeah, great. That's awesome because I want to get through the questions. I think that's really
Yes.
the. Thank you very much.
So we must use the MRI, we must target the biopsies, and we apply active surveillance as long as possible for low-risk disease. The MRI inclusion as screening protocols reduce the number of men that undergo biopsies and detect more high-grade and less low-grade PSA. That's the main message here. We had the PSA, and now we combine the PSA with the MRI to focus on the men with high-grade prostate cancer. Then, for individual early detection, normally is recommended for age more than 50, men from year 45 with family history, men of African descent from 45, and men carrying this kind of mutations. If you have this kind of gene mutations that is now widely diagnosed, also must be checked from 40 years. This is talking about the same. Then initially we do PSA and digital rectal examination. The use of digital rectal examination in primary care has a good sensitivity and specificity. But when we have a normal PSA, we combine with the digital examination. If both are normal, the screening is done. If we have abnormal PSA, then we need to introduce different techniques. In general, if we detect a man with baseline PSA less than 1 at 40 years and less than 2 at 60 years, they are at decreased risk of prostate cancer or death. Then the retesting interval can be therefore be every 2 years for those initially at risk, or postpone up to 2 to 8 years in those which has this low risk. It means if you have at 40 years PSA lower than 1, or you are 60 and have PSA lower than 2, you are not recommended to repeat before that 8 years because it's supposed that you are at a very, very low risk. How we detect if we need a biopsy, if we have suspicious for PSA or for digital examination, how we decide if we are under risk? There are different calculators based on clinical aspect like age, digital examination, PSA. We can check on the web different calculators that can help us to decide if we have clinical risk or not. But the main tool nowadays is the prostate MRIs. The prostate MRIs classify the patients in a scale from 1 to 5. And this 1 to 5 scale is what we will use to decide if we will biopsy or not that man. There are also some markers in urine and in blood that we can use to help to decide if we need to do biopsy or not. But in general, these are the clear recommendation in guidelines. For early detection and for screening, do not subject men to PSA testing without counseling them on the potential risk and benefits. This is a strong evidence. Offer an individualized risk-adapted strategy for early detection to a well-informed man with a life expectancy of at least 10 to 15 years. Offer early PSA to the group of men that we have seen before in the slides, and offer a risk-adapted strategy with follow-up intervals of 2 years for those that are initially at risk. Men with a PSA more than 1 at 40 years, men with a PSA level of more than 2 at 60 years should be screened every 2 years. The other group can be screened only every 8 years. In asymptomatic men with a PSA level between 3 to 10 and a normal digital examination, repeat the PSA before doing nothing more. Repeat the test and check that is repeatedly abnormal. In asymptomatic men with a PSA level between 3 and 10 and a normal digital examination, use one of the following tools for biopsy indication: risk calculators or MRI, mainly MRI. You can use also some biomarkers in urine and in blood, but they still are like not well established, and we need much more investigation in this field to validate the use of these tools, not yet validated. Stop early diagnosis of prostate cancer based on life expectancy and performance status. Men who have a life expectancy less than 15 years are unlikely to benefit from the screening. For the clinical diagnosis, normally we base basically on the PSA and the digital examination. If based on the PSA and the digital examination, we think that you are at risk, that you have probably some prostate cancer, then is when we select the patients to do biopsy. To do the biopsy, we use the transrectal ultrasound and ultrasound-based techniques. Standard transrectal ultrasound is not reliable at detecting prostate cancer, and the diagnostic yield of additional biopsies performed on hypocoagulations is negligible. New sonographic modalities such as microdoppler, sonelastography, or contrasted enhanced ultrasound are improving the diagnosed capacity of the ultrasound. But till now, the best tool is the MRI. The MRI has a pool sensitivity of 91% and a pool specificity of 37% to detect prostate cancer, to detect high-risk prostate cancer. MRI pool sensitivity and specificity were really high, 95% and 35% for high-grade prostate cancer. It means if in the MRI there are no pictures of tumor, it's not suspicious of tumor, you have only like a 5-10% of chances of having a high-risk prostate cancer. If the MRI is positive, so some lesion, you need to go to biopsy that lesion that you are seeing in the MRI. If the MRI is negative, your chances are less than 10% of having some significant prostate cancer. we need to focus and target
Doctor,
the biopsy. Yes.
do you mind if I jump in? It's just that I think I'd like to get some Q&A going, if that's okay. I mean, how many slides do you have left, please? It's quite a lot.
Like 10.
Yeah.
Okay.
Yeah. I think what
You
I'd
told
like
me
to do.
1 hour.
Yeah. I mean, what I don't want is, and I work in a
I try to
consulting.
summarize. Okay. So we diagnose the prostate cancer, and if we try to treat the prostate cancer, the standard treatments are radical prostatectomy and radiotherapy. What's the handicap of these treatments? The adverse events. You will have incontinence, you will have erectile dysfunction, you will have change on your sexual life, and loss of penile length in the surgery. In the radiotherapy, you will have toxicity, you will have rectal bleeding, you will have diarrhea. So the side effects of the curative treatments are high for the cases of prostate cancer, and it's only deserved when you have a high-risk prostate cancer. In that cases, you need to follow the treatments. Radical surgery or radiotherapy. In case of high-grade prostate cancer, you need to follow these treatments. When you have a low-risk prostate cancer, you can select a passive attitude. You can observe the tumor, and you can decide if you can treat the tumor later. This is called two strategies: active surveillance and watchful waiting. You can observe the patient, you can repeat tests, and only if you see that the tumor is progressing, then you jump to another active treatment.
Dr. Juan, do you mind if I jump in? Hi, this is Lamise. If it's okay, can we pause the slides and just ask a few questions? I think there's some kind of real life scenarios that a few people I think would like some answers on, and I think it will be just good, just in the interest of time, to make sure that we can address the questions, and then if we can go back to some of the treatment outcomes, then we could possibly do that. But just so that we can really make kind of the most of the time to answer some of the questions, I'm going to jump in with one, and then Andy, I'm going to hand over to you because there's quite a few coming through. And I'm going to kind of throw this in from a woman's perspective. Andy, if you don't mind, I'm just going to jump in with this, and then you can take forward the other questions. And that's really about hormones, because I think hormones for women get an awful lot of attention and a lot of airtime, and there's a lot of stigma around that. But some of the age ranges that you've mentioned, 45, 50, so on, can you just very quickly in a couple of minutes just talk about men's hormones? I've heard the term men's menopause, and I'm just going to put it out there. But is there a link between kind of these age groups and hormone changes in men that we should really be aware of? Because I think a lot of the time those hormone changes can affect mental health. It can affect, increased risks of certain diseases. So can you just spend just a couple of minutes, and then we've got quite a few other questions to get through, just touching on hormones.
On humans? Sorry?
Hormones, male hormones, and the changes kind of throughout as one gets older in their 40s and 50s and so on.
There are no established relation between main hormones changes and relation to prostate cancer.
Okay, so it is not associated with hormone changes.
No.
The age groups that you've mentioned, 45 above 50, is purely age related.
It's purely age. Of course, age related, and one of the changes with the age is some hormonal changes, but there are no studies that really establish any direct relation. And what has been seen is that testosterone, that we thought during years that could increase the risk of developing prostate cancer, the use of testosterone is not related to increased risk of prostate cancer.
Okay.
And the patient with prostate cancer, of course, if you have prostate cancer, you cannot receive testosterone. But if you are healthy, receiving testosterone is not increasing your risk.
Okay. And a few other related questions. Do you want to jump in with them?
Yeah, sure. Thanks, Lamise. A couple that came through. Someone mentioned, is there any correlation between prostate cancer and eating disorders?
Sorry?
Was there any correlation with eating disorders?
ED disorders?
Correct.
No, but some of the ED cases could be at the initial diagnosis could bring to diagnosis of prostate cancer. Some of the issues that happens in the prostate with whatever disease affecting the prostate, inflammation, growing, or prostate cancer, some of the signs or the symptoms could be this erectile dysfunction issue with no clear reason, not clear link or relation with the cancer, of course. Mostly of the cases benign hypertrophy or inflammation. But in the evaluation and diagnosis of the erectile dysfunction, we must look and rule out for prostate cancer. Of course, we need to do PSA, digital examination, and prostate evaluation.
Okay. When you say PSA, doctor, could you just remind me PSA again, please?
PSA is blood test that is prostate-specific antigen, and is what we use mainly for the screening. You perform a single blood test, and in the blood test, they look for this protein that is linked to your prostate. And then it means if you have prostate cancer, in most of the cases, you will have high PSA.
Okay. So there is no need for what I would call the invasive test that men used to go through about 10 years ago.
This is still recommended, but in the last studies, really the specificity and the value that it brings is every time lower and lower.
Okay,
And then
great.
if we have PSA and we have the MRI, the
Okay.
digital examination can help to assess when there are a clear diagnosis, to decide treatments, to decide what kind of surgery, but to the diagnosis or to the screening has not much value, not more value.
Okay, there's a whole bunch of questions. I'm just going to follow on one of my questions. I think that if someone felt like they had symptoms, which we've spoken about, is it easy to get to request a PSA blood test and to them to go through that process?
Yeah. So if
Great.
you have some of these symptoms that are not related linked to prostate cancer, of course you don't must think that maybe I have a prostate cancer. This is common, that happens for normal benign reasons, prostatic hyperplasia, inflammation, infections, 90% of the cases.
Yeah.
But you must look for advice, check what happens and how you could be helped. And we, of course, one of the things that we will check if that you don't have any sign of prostate cancer.
Okay, great. Some of the questions we're getting through is, do you see any association with prostate cancer and use of plastic in the use of cooking, storage, etc.?
Not demonstrated. No
Okay.
studies yet in any that factors that you can ask me are conclusive. As I have read the guidelines, I have read all the review literature, and we don't have any clear associated with any risk factor. There are a lot of studies. You can read in internet, tomatoes prevent prostate cancer. Okay, some study says that prevents, some another study says that is not preventing. So
that's fine. Okay. In terms of this, in summary, I mean, you've presented us great depth in terms of slides to begin there, but what would you say in summary were early signs, symptoms to look out for?
the symptoms are really not reliable. We cannot wait to feel symptoms of prostate cancer because it will be late. If we have symptoms related to prostate cancer, normally it means advanced disease. Most of the times when we feel symptoms are not related to prostate cancer, are related to benign diseases.
That's a really important point, isn't it, Then it's about not scanning is the wrong word. I mean, you would
Early
need to correct me.
detection. Early detection.
Yeah, thank you, Lemise.
So the general recommendation, the main recommendation is men between 50 and 70 years old. If you have not done before, make a screening for prostate cancer. You can go to your urologist. You can follow basic ultrasound and PSA. And as in the guidelines say, if your PSA at 40, 50 is less than 1, or at 60 is less than 2, you don't need to repeat until 8 years more. But if at that age your PSA is over that limit, it's better to review every 2 years.
That's really sound, I think, and clear advice. But say myself, I'm 47. I did a prostate exam 7 years ago. I mean, should I be looking to go ahead for another one now, or wait until I'm 50?
If it was at 40 was less than 1, you can wait till 50 to repeat it.
Great. Okay. So
if you have done no test before, you can start now.
I'll jump in.
Thank you.
Actually, one question.
Yeah, go ahead, Lemise.
With one question that came through earlier regarding, and I'm sure I read it somewhere, just regarding hemorrhoids, and if that has any part to play in, I guess, cancers in general, but prostate cancer, it says in particular.
Your question is if hemorrhoids is
Hemorrhoids,
linked to...
yeah.
No, there are no direct link.
No direct link.
No, of course.
And what about some of the other cancers that you suggest men really keep an eye out for as the years pass? I know you focus a lot on prostate cancer, but is there other kind of diseases and well-being topics that you think men should really have at the forefront of their mind when they are caring about, their health and their well-being outside of prostate cancer, which we know is,
Yes,
is quite a common one?
Prostate cancer is special because it's not producing symptoms normally until it's advanced disease, and only some kind of well-addressed screening is valuable in that side. But for men, you will have also testicular cancers, but normally you will touch something in your testicles. Then if you touch a lump, you feel some pain that is not disappearing, something strange, it's better to consult and check. Of course, whatever lesion in the foreskin, in the penile area that is not disappearing, whatever skin lesion should be screened also, because could be some of the common cancers in that area. And internally, we have also bladder cancer, but this apply also for men and women. And bladder cancer normally produce blood in the urine. Always, if we have blood in the urine, we must be screening to rule out what happens, if stones, infections, or tumors. And in the kidneys, it's the same. The kidneys can produce no symptoms until it's well advanced. And then the most of the kidney tumors that we can heal are discovered by ultrasound by chance. We go to the doctor for another reason, or maybe some abdominal pain, some unspecific symptoms. And if we do an ultrasound, we find a lump, a tumor in the kidney, and it's the moment that it can be healed or treated. But it's normally producing no symptoms.
Okay.
Okay, thank you. A couple more questions coming through. Is there a digital test for this? I know we talked about the PSA, but was there a other test in terms of a digital test? Was a specific question for you?
Another test, blood test or urine test?
So it's blood test, urine test, MRI are the three tests.
There are urine and blood tests specifically designed like genetic markers or protein markers that can help to decide in the diagnosis and in the treatment. Okay. But these are still under study. They have been used in the last years, and we need still more years of investigation and use to have clear indication of these tests. Now different clinics are offering different genetic panels in urine or blood to try to help to take decisions, but still no clear recommendations, which one is really good or not.
Okay, thank you. I think there's a nice question here. It's about people below. I mean, you've talked about the at-risk age group being 50 to 70, which is slightly different to when I was a few years ago. People saying it's more 40 to 70. There's a question here about we have a large population of men in their 20s and 30s. How should they be approaching? I mean, and they're actively listening on this webinar. How should they be approaching the topic of this topic? I mean, should they be doing anything, watching out for anything? What would your advice for men in their 20s and 30s be, please?
At that age, is not really common, or it's really unlikely that they could have this kind of diseases. And as lifestyle is also not clear recommendation what to do to avoid. But of course, a healthy life, a healthy lifestyle could help to prevent. Then he can focus on or transmit the information maybe to his fathers or his grandfathers if they are not aware of the information. They can help to have right information about what is prostate, when the prostate needs to be checked or not. This kind of help is what could be really hoped from them.
So it's very much a, is there historical occurrences in your family that you should be taking this in your 20s and 30s, then you perhaps should be taking more tests.
Not at that age, but start early at 40. If you have direct family history of prostate cancer,
Okay.
Mainly if your father or your grandfather had prostate cancer, not prostate enlargement, not symptoms of prostate cancer, then you must start your screening at the age of 40 better.
I'm going to jump in with Andy.
Go ahead, Louise. Yeah.
I guess just one, as you said, Andy, about kind of our colleagues who are in their 20s and so on. I think what we're seeing more and more, Doctor, is I know you touched on the lifestyle around drinking, smoking, and so on. One thing that we're seeing a lot of, and we didn't really understand what the impact would be, and maybe we're starting to see that, is around vapes. I know that they get a bit of bad press. So are you starting to see some of those, the longer term side effects of vapes?
Yes, vapes is considered for us as doctors, the side effects of vapes will be the same as current smoking, as the traditional smoking. There are no real difference. You are bringing this substance into your lungs, and then you are avoiding only the paper, but we don't know really what there are in the chemical of these vapes. And some of the lung reactions that we are seeing are worse than the classical tobacco. So it's a bad habit, a toxic habit that could damage your health the same or worse than the traditional smoking.
So I want to emphasize that point. So the negative effect on your lungs having vapes in some cases is worse than smoking cigarettes.
Yes, of course.
Make note, anyone on this call who has a vape in their pocket or on their desk, take note of that.
It's not safer than current smoking, classical smoking.
Yeah. So you're not doing something healthier than smoking by having a vape.
No. It's different, but not healthier.
Yeah.
Okay. Thanks, Lamise. There's a couple of questions coming through. One was about testicular cancer. Is it more common in men who are in their 20s, or is there a specific age group where this is more prevalent? Doctor, I don't know if this is a topic you can comment on.
Testicular cancer has normally two peaks of incidence in young men around 20 and later around 60. It's normally clearly symptomatic. You touch something in your testicles. Then what you should do is if you touch something different, normally you go to the doctor. You are not hiding it or avoiding to consult. Normally you are coming to make a consultation. It's strange that the testicular cancer is not well detected. The problem is in some cases it's really quick, and when you detect and come to the doctor, maybe it's also in a advanced stage. But the good news is that there are very good treatments for testicular cancer, and most of the cases, and also advanced cases, advanced stage diseases, are well solved and cured.
Okay, thank you for that. Lamise and Maha, am I missing any questions in the chat which we should be calling out?
No, I don't think so. I think there was just a comment about, the messages that, although it's quite common, it can be treated, and early detection is key. So treatment is very effective in most cases of early detection. Is that right, Doctor?
Of course.
Yeah.
In early detection, we can solve the cases. In advanced detection, we can treat, but most likely not heal the case.
Yeah.
Okay. There was one question coming through here. It's just one to ask. Is it true that maintaining an active sexual life helps lower prostate cancer? So does a healthy sex life lower prostate cancer?
Sorry, I have not understand.
Does having an active sexual life style, I suppose, help lower prostate cancer? Is the question.
It seems, but there are no conclusive results. All these things has been studied. It's a higher ejaculation rate, maybe it's associated with low risk. It seems that active sexual, but also it must be healthy activity. I mean, also some sexually transmitted diseases and some issues are related to increased risk of prostate cancer, also papillomavirus. So it depends.
Yeah, you mentioned gonorrhea as well earlier, so that's obviously in that area as well. Final question coming through. I don't understand. What is the long-term effect of ED medication like tadalafil?
Is safe, are thought to be taken as chronic treatment. And if your heart is healthy, you don't have specific heart diseases or cardiovascular diseases, the treatment is like taking one pill for the hypertension. It's safe and thought to be taken during long time.
Okay. So, Doctor, was any final slides, any final comments? I mean, I've kind of hijacked your slides at the end there. My apologies for that. That's what happens when you work in a consulting business. It's but we really wanted to get through the Q&A with our employees here, and I think it's such an important topic.
We do appreciate pausing your slides for us to get to the questions. So maybe any final thoughts? Yeah.
I can put the general recommendations. Summarizing is like the summarize of evidence is like 5 slides only. If you allow me, I will put these 5 slides. That is the final points related to prostate cancer. Okay.
I think we've got about 1 or 2 minutes left, and then I think we'll have to drop. But please do.
So related to prostate cancer, what are the active recommendations? No active treatment modality has shown superiority over any other active management options or defer active treatments in terms of overall and specific prostate cancer survival for clinically localized low and intermediate risk diseases. It means for low risk cases, whatever treatment has been proved same effectiveness. No difference between the treatment that you choose. Offer watchful waiting policy to asymptomatic patients with clinically localized disease and with a life expectancy less than 10 years. If your life expectancy is less than 10 years, maybe you don't need any treatment. You only need to be observed and managed symptomatically. Inform patients that all local treatments have side effects. Inform what are the effects of having a surgery, a radiotherapy, any treatment. Related to surgical treatment, radical prostatectomy can be safely delayed for at least 2 months from diagnosis and any risk category. Sorry, I have gone. Radical prostatectomy is not urgent, can be delayed at least 3 months. Inform patients that no surgical approach, open, laparoscopic, or robotic, has clearly superiority in terms of functional or oncological results. Whatever surgery done by good doctors, good surgeons, are equivalent to oncological results. When a node dissection is deemed necessary based on nomogram, perform stent. This is technical issues for surgical. You don't mind about it. And this is related to surgical treatment. So it's not urgent, can be delayed, and all the techniques have been shown same effectivity. Regarding radiotherapy, offer intensity modulated radiation therapy or volumetric. It's all technical, no interested for you. For surgical and radiotherapy, I'm talking only about the specific technical issues. But as I cannot talk about the focal treatments, this slide I will jump because it was in the previous slides and it's talking about the focal treatment. So the classical treatments was as radiotherapy or surgical removal. These are very curative for high aggressive prostate cancers, but for low risk prostate cancer, we must focus on focal treatments. And cryotherapy, high intensity focused ultrasound are the treatments that we can offer nowadays to treat the non-high risk prostate cancers and treat in an active way to solve that cases with the minimum side effects. To preserve the quality of life in these means, we must do these guidelines. Advise eligible patients for active surveillance that global quality of life is equivalent for up to 5 years compared to radical prostatectomy or radiotherapy. Discuss the negative impact of surgery on urinary and sexual function, as well as the negative impact of radiotherapy on bowel function in these patients. Advise patients treated with brachytherapy of the negative impact on irritative urinary symptomatology at 1 year, but not after 5 years. So explain what the radical treatments are producing. And summary of evidence say that prostate cancer is a major health concern in men with incidence mainly dependent on age. Genetic factors are associated with the risk. A variety of dietary factors have been associated with prostate cancer incidence and prognosis. Testosterone is safe in hypogonadal men, is not producing increased risk of prostate cancer, and no conclusive data exists which could support specific preventive or dietary measures aimed to reduce the risk of developing prostate cancer. It will be the end of my speak. I missed to talk here in the middle of the focal therapies. That is what I want to focus.
I know.
That in that cases of non-high risk prostate cancer, focal therapies and conservative therapies should be the first line approach and not the radical treatments.
Thank you, Doctor. Very, very much appreciated. And I think there's some really key points for people to take away from this. And I think it's just been really informative. So thank you so much for your time. Sorry we couldn't get through all of your slides. I hope you can appreciate just how many questions, our 200-300 attendees had that, obviously come from their experience and things that they've heard. So I think it was really important that we get to those questions. So thank you. I'll put my video on. So thank you so much for making time to speak to us. Thank you everyone who attended, and we hope you found it helpful. And we know there's a whole range of men's health and well-being topics that we need to talk about, and this was a really great starting point for us to really focus on men's health. So thank you once again, and have a great day, Doctor. We appreciate your time. Thank you very much.
Thank you all. Thank you. See you.
Absolutely. Thanks.
Thank
Bye.
you.